well, thank you for joining us today in this session, Standardizing PCI with Robotics and Smart Procedural Automation. So I'm Ryan Mader from Spectrum Health in Grand Rapids, and with me are Doctors John George, Bill Lombardi, and Jean Fagedet. Disclosures for this session: the statements by customers of Corindus, a Semen Healthineers company described herein, are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory and many variables exist, there can be no guarantee that other customers will achieve the same results. Myself, Doctors George, Lombardi, and Fagedet each receive financial support from Siemens Healthineers and Corindus for our collaborations. So the agenda today, we will start with Dr. John George, who will present on CorePath GRX overview. We'll then move on to Bill Lombardi, who will present on creating PCI efficiencies with technique and smart procedural automation. We'll then move on to Dr. Jean Fagedet for clinical impact and case review early experience with technique, and then we'll finish with a panel discussion. The objectives for the session today are to discuss current features and capabilities of the CorePath GRX vascular robotic system through clinical data and real-world applications. We'll educate clinicians and healthcare professionals on new tools and techniques designed to standardize treatment protocols, increase efficiency, and improve patient care. And we'll share early experience with expanded series of smart procedural automations through case review. And with that, we'll move on to Dr. John George.
Thank you, Ryan. I'm excited to be here at TCT Connect. I will be going over the CorePath GRX overview today with you. So as you know, in the cath lab, interventional procedures have advanced a lot. Back when Dr. Andreas Grunzig performed his first angioplasty in 1977. He started doing the procedure at bedside, exposed to radiation as we are today. And although we've had a lot of technological advances in the cath lab related to the fluoro systems with implantable devices, with the techniques that we do our procedures, it has largely been unchanged. We are still exposed to the same risks of radiation, the orthopedic risk from our lead aprons, and the precision that is required in the complexity of cases that we do has not changed until today. So today we'll be talking about CorePath and robotic-assisted intervention, which has changed the paradigm on how we do these procedures. So robotics in the interventional suite involves a bedside unit separate from the bedside procedure. So the bedside unit involves a robotic arm that is simple to set up and does not change the workflow necessarily, other than having the robotic arm fix the devices during the intervention, and allows you to image the procedure, the rest of the procedure, the way you would in a cath lab. The workstation, which is removed from the table itself, can be outside the cath lab and allows for precise robotic control of the guide catheter, the guide wire, and the monorail systems that involve balloon angioplasty and stenting during the procedure. The workstation can be completely radiation shielded if it is placed within the room, or as mentioned, could be outside the room. You have a large monitor that allows you to visualize what's being done right at the level of your eyesight, adjacent to where the operator is sitting. And the technique, procedural automation, will be discussed in future slides. So if you look at traditional versus robotic intervention, there's a variety of obstacles that have been overcome. We know that as far as assessing anatomy in these cases, often there is a struggle in being able to visualize the angiographic procedure, having to lean over the patient bed to see what's being done on the screen across from the operator. The robotic-assisted intervention now allows close proximity, ergonomic visualization while the operator is seated, and seeing the procedure magnified. Navigating the lesions with traditional intervention requires trial and error with spinning of the wire to cross a lesion, which can now be automated with robotic techniques, which we will go over in just a bit. measuring and determination of length of lesions and placement of stents has been based on an eyeball estimate other than using intravascular imaging. But now with robotics, sub-millimeter precision can be obtained, allowing precise measurement of lesions. As far as positioning stent, again, 1 millimeter precise positioning is available with robotics by individual movements of these devices, millimeter by millimeter. And while these devices are being positioned or deployed, as far as stents are concerned, the device can be completely fixed with the robotic arm as opposed to it being loose during traditional intervention. So there's significant advantages with robotic intervention compared to our traditional pathways. So what is the clinical evidence for robotics? Well, we have the CORA PCI trial that demonstrated over 99% clinical success in complex cases, and while maintaining comparable procedure times compared to manual PCI. And this was published in JACC Cardiovascular Interventions in 2017. The PRECISE trial further demonstrated a 95% reduction in radiation exposure to the primary operator. This is not surprising, having stated what I did before, that the operator is removed from the bedside, either in a radiation-shielded cockpit or outside the room for the intervention. Recently, what's really interesting is that a cohort analysis, which was a single-center trial, demonstrated a 20% reduction in radiation exposure to patients compared to manual PCI, which has a variety of reasons, and this was published in CIRC Cardiovascular Interventions just this year. And finally, in comparing robotic versus manual PCI, with measurement of lesions with robotic PCI, there may be a significant reduction in errors related to measurement and need for extra stents, especially with longitudinal miss, as demonstrated by the study published in 2015.
Welcome to TCT Connect and the Siemens Healthineers initiative discussing robotics in PCI. I want to talk a little bit about some of the new smart procedural automation to help improve the minimum competency of operators by improving skill sets and efficiencies through automation in the cath lab. So historically in the cath lab, the biggest challenge for any intervention to be done is the amount of procedure time it takes to get the wire to be manipulated across and deliver devices. This is often done via trial and error for navigating vessels, and crossing lesions isn't predictable. However, with robotic-assisted PCI, what you can do is you can create algorithms based on the techniques of the most skilled operators. So effectively, you can go out and look at, how Bryson DeChambeau hits a golf ball, and we can make the robot hit the golf ball exactly the same way. That way, everyone gets the opportunity to play at that same high level. As automation improves, this should make navigation, lesion crossing, and delivery of therapy much quicker, much more reliable, much more predictable, and much more efficient, which is good for both the operators and patients by reducing contrast and radiation in future. So the smart procedural automation is called the Technique IQ series. It's a series of automated robotic movements. Rotate on retract was the first automated motion in the series. There's now 4 new. One is spin and wiggle. These are both wire manipulations. Daughter, which is a catheter manipulation, and constant speed, which is both wire and device. So when rotate on retract was first introduced, what happens is the wire, when you pull back on the joystick, the wire turns 210 degrees. By doing that, you've effectively just made the motion forward and back to drive the wire, and it reduced wiring time by 50% from a series of expert interventionalists. So even though people were highly skilled, by just letting the robot do the work, it actually improved our procedural efficiencies. So this is what spin will look like. And you can see it's just a high-speed spin. It's something you do in the cath lab every day. We just looked at it through a variety of operators to look at what the rotational speed and rotational force was, and used that to be mimicked by the robot. The next automated motion is one called wiggle. And again, this is something we often do in the cath lab. where the wire is rotated back and forth on a certain set of angles. Those were determined by looking at that to highly skilled operators and what their rotational arc and speed was. The next is a classic maneuver that we do with balloons and stents, which is called doddering. So as you can see here, here's the robot just doddering the catheter, trying to help keep the nose cone free and devices able to be delivered. And the last would be a constant speed. You can see using this when doing laser atherectomy or rotational atherectomy or orbital atherectomy, or when doing imaging to improve the outcome of procedures by giving an automated speed and much more consistent delivery. How this looks is just drop-down menus on the control panel of the robot. As you can see, you just select ROR, or you can select wiggle, or you can select spin. You just then push the joystick back and forward. And again, this makes it much simpler. You're not having to do anything other than push forward and push back. I've actually seen my 17-year-old son wire coronaries very effectively because this now becomes much more like a video game. So all of these combined movements are designed to make us better. Here's what it looks like in real time. If you look at the upper two on the left is without automation. With the right, it's with automation. You can see how the spin just easily crosses and allows you to keep going faster. If we look at the bottom, different set of angles, but same challenges. You can see the manual gets into issues with prolapse. Spin reduces friction and allows it to easily traverse. So automation will help improve efficiency and safety. Nowhere on earth do robots and automation not improve efficiency and safety. If you think about flying airplanes, self-driving cars, how cars are built, many things built by industry. Now, for adoption to occur, it requires something called purposeful practice. It means you actually have to change how you do things. But if you do change, it will allow you to be much more efficient, much safer for yourself, much safer for your patients. And if you have any questions, please don't hesitate to email me. My email address there on the slide. Thank you very much for having me this evening.
It's my pleasure today to report our experience in Clinique Pasteur Toulouse with robotic assisted PCI, and no disclosure particularly to say. And we started the experience 1 year ago, and we are now more than 180 consecutive patients performed by the remote PCI with the current-induced robot assistance from the control room. On this view, you could see the robotic assistant placed in the control room and not in the cath lab. And we have the possibility from the control room to maneuver all the joystick of for the robotic PCI with the guiding catheter, the guide wire, and the device, and in addition to control all the position on the table and the CR. What you could see that the patient is alone on the table, connected from the sheath and the guiding 6 French or 7 French guiding catheter to the robot. And but the only thing that the nurse will do is a balloon inflation. We could be performed in the control room, but in our center, the nurse, which is totally protected from the X-ray exposure, is taking care of the balloon inflation. Here you could see some example that we have done. At the beginning, we select easy cases with a proximal lesion on the single patient with single vessel disease, like CLD. Progressively, we increase the difficulty of the procedure with, for example, here a long proximal and mid-RCA lesion. Here, a patient with previous bypass surgery with a long disease in the vein graft, treated with a multipurpose catheter. Then we move through to the progressively to more complex lesion, including bifurcation lesion. Here is an example of LAD diagonal bifurcation lesion, treated with 2 wires, kissing balloon technique and provisional stent procedure. Here, patient with multivessel disease with critical lesion on the mid-LAD OM branch and one OM first and OM2 branch, and that's a result on the LAD on the left and the result after stenting of the OM1 and OM2 branches. Patient with left main disease and an ostial RCA disease, and here are the result on the left main and right coronary artery. And finally, a patient with a three vessel disease with a mid-LAD OM branch and the right coronary artery, and the result of the LAD, OM, and RCA. So the result are the following. On the first 180 patients, could see that we have a majority of male, 30% of diabetic patient, 50% of previous PCI. Concerning the clinical and angiographic characteristics, 39% of patients with single vessel disease, 38% with two vessel disease, 22 with three vessel disease, a majority of LAD and RCA lesion were treated. Angiographic and procedural data, in 70% of the case we did the procedure via radial access. Most of the time 6 French, more than close 92% of the patient were treated with 6 French guiding catheter. We perform PCI one vessel in 70% of the cases, two vessel is 26%, and three vessel in 4% of the cases. Concerning the severity of the lesion, bifurcation in 22% of the cases, ostial 12, long lesion more than 25 millimeter in 29%, and 19 in the calcified lesion. No chronic total occlusion were performed via with robotic assistance. That's the result of the procedure. You could see here the mean contrast volume 200, mean fluoroscopic time 17 minutes, mean irradiation dose 1720, procedure duration 58 minutes, and only 3 patients required a manual conversion. Concerning the result in hospital clinical outcome, you could see that mean hospitalization time is 3.9 days, mean post-procedural hospitalization time in days is 1.5, no patient died. We had 1.5 patient who developed MI post-procedure, no patient need repeat PCI, no patient had stroke, and very few patients had renal failure. So these globally are good results. And in conclusion, we could say that PCI using robotic assistance is feasible, safe, with no increased risk for the patients. Multiple lesion angioplastic can be performed during the same procedure, and complex lesion, like bifurcation lesion, ostial lesion, can be safely treated. Compared to the manual PCI, it's a little bit longer procedural duration, mainly due to the preparation time of the robotic on the table. We had also a higher contrast volume and a longer fluoroscopy time, but this normally should be improved with experience with this technique. The technology improvement for the future, certainly for the AV calcified lesion, at present time you cannot use a rotablator, for chronic total occlusion, and for peripheral artery disease. What's important is to prepare all the team for remote PCI program, and we have to organize the cath lab with robot station in the control room, all the TV screen, AngioLive, reference image, hemodynamics, ECG, table and patient view from a camera are report in the control room. Contrast injection and balloon inflation with a deflator can be performed from the control room. We have to prepare the team with specific training for nurses, with a dedicated group of 4 to 5 nurses really motivated with this type of procedure. And in the same time, we have a specific training for physician, for operator of the team, with a group of 4 physicians motivated with a daily procedure and progressive increase of the target lesion complexity. We had really the chance, really happy to did one of the first patient with a new smart procedural automation. And with this new automation, we can use the ROR, rotate on retract, that we had on the previous software, and the 4 new possibilities: the wiggle, which is an oscillation, give you an oscillation of the guide wire when advancing it, and our retraction. And this had to, in the guide wire navigation, mainly distal to the lesion. When we move your guide wire distally to the lesion, to the distal vessel. It's interesting also when we cross long diffuse disease, sometimes calcified, and particularly when you have tortuous vessel. This is for the wiggle. The spin is also interesting. It's really the function that we did also manually with our fingers, with a full clockwise and counterclockwise rotation of the guide wire. And this is really interesting to and help to cross the lesion when we have a complex lesion, eccentric lesion, a tortuous vessel. This is really useful. The daughter is implemented for the device, balloon or stent. It's what we did sometime when we have a very critical high grade lesion, really difficult to cross. It's exactly the same rapid back and forth motion on the device when advancing. And this really is helpful to cross a high grade lesion with the balloon of the stent when it is calcified, and sometimes when we have a quite long lesion to cross. The constant speed is really interesting. Can be performed with a wire or with the device, and we have the possibility to use the 2 or the 5 millimeter per second. For me, I would prefer the 5. The 2 looks a little bit too slow. But this is very interesting to measure precisely the length of the lesion, and in other words, to really select precisely the length of the device that we will use, and particularly the length of the stent. This constant speed can help you in the measurement of the lesion, until when you move antegradly the wire of the device, or when you remove retrogradely the wire of the device. Some example here with a patient with LCX and OM lesion, and you see a critical lesion on the OM branch. In this particular case, we advance the wire using the spin, and then after the crossing the lesion, we move to the wiggle in order to advance by oscillation the wire distal to the lesion to the distality of the vessel. You could see here we pull back a little bit, and then we advance the wire using the wiggle, and you could see that particularly in the distality of the vessel, which is really tortuous, you could see here during the control injection that you could place safely the wire distally, and this is the final result. another case of LCX lesion, interesting because here we have a critical lesion of the circumflex covered by the stent here, and a critical lesion at the origin of this branch. And what we have done is to place the wire using first the ROR in order to place the wire in the smaller branch. Then we cross the lesion with using the spin. And finally, after crossing the lesion, we use the wiggle in order to place the wire distally. Here you could move to the next view, and you could see here that we can, with the wiggle, place the wire more distally. Finally, the wire placed in the OM branch, and then with the wiggle, we advance the wire, making a loop to the distal LCX. So then, after doing that, we advance the stent. Remember that on the baseline anatomy, it was very high-grade lesion, and using the daughter effect, we could place the stent with this good final angiographic result. Then here, an example of a long RCA lesion involving the proximal, mid, and distal, and here using the spin to cross the lesion and the wiggle, and you could see the oscillation on the wire in the distality. We could place the wire in the PDA, and this is the final angiographic result. So here the last example is the LAD lesion with diffuse disease on proximal and mid LAD, and again to show you the use of the wiggle software in order to place the wire in distality, and this is the final angio. So now we are, so this new software give really new possibilities, new advances for the operator in order to facilitate the treatment of complex lesion. Now we will finish this presentation on presenting you the Navigate study, which will be a multi-center, randomized, open-label, international post-market registry, and we plan is to include up to once of the patient with a primary endpoint, which is a technical success defined as a clinical success and successfully completion of robotic assist PCI, absence any unplanned conversion to manual in the absence of in-hospital MACE, and also defined as the angiographic success with residual stenosis after stenting less than 30%, a final TB-free flow at the end of the procedure without any in-hospital MACE. The secondary endpoint of the Navigate study will be the following. First, the guide wire time, which is the time required to advance the guide wire from the tip of the guiding catheter to cross the critical stenosis and had the safe deployment of the wire tip in the periphery of the vessel. The fluoroscopy time to cross the lesion and the total procedure, the contrast used to cross the lesion and during the procedure, the procedural time, which is the time of the sheath, from the sheath insertion to the complete removal of the final catheter, the subject radiation exposure, the conversion to manual, defined as partial manual assistant or manual conversion. And of course, we will look at the risk of complication, coronary dissection, or coronary perforation. So I would like to thank you again to give us this opportunity to really perform in our first patient this new software with the ROR, spin, wiggle, and daughter, and constant speed, which really, I'm sure, will give us better result less complication, and we give up the possibility to treat more complex patient in more complex lesion in more complex patient. Thank you.
All right, well, I'd like to thank the three presenters. I think really nice presentations and very insightful on kind of what robotics offers and new directions. So a question I'd like to pose to the group and like to get a response from everybody. So we saw in Bill's presentation the preclinical videos showing the efficiency with which use of these automated maneuvers can get wires where you want them to go. And I think in Dr. Fajadeh's presentation, some very nice clinical examples of the new techniques. And just a question for everybody, and maybe Dr. Fajadeh, will start with you. With these three techniques, you seem to suggest that maybe the wiggle technique is what you're anticipating will be best for navigating tortuous vessels and maybe across diffusely diseased segments, and that the spin may be best for crossing lesions. Now that you've had this in your hands, what do you anticipate going forward is going to be your go-to maneuver for different lesion types?
I think that these three measure really improvement. We had previously the R1. Now we have the spin, the wiggle, and the daughter. When you look, the daughter is only for the balloon and stand. But concerning the wiring technique, it is true that it's really impressive to see and to feel that when the spin and the wiggle is giving exactly what we are doing with our fingers. In other words, when we manually, we have to cross critical, complex lesion, we are advancing the wire slowly with the torquer. And this, the hour, we give you this kind of feeling turning the wire. When we are really approaching the lesion, and particularly in the tortuous vessel, using the spin, you could really clockwise and counterclockwise cross easily the lesion. And then for me, the wiggle is really interesting when you have a proximal lesion, for example, LAD, and then we need to place the wire after crossing the lesion in proximal segment to place the wire in the distal LAD. Activating the wiggle, you advance your guide wire, and really easily the wire is crossing all the descending, all the LAD. For me, it's really impressive because this really transfer via the joystick what we are manually doing in a routine practice.
Yeah, nice. And how about John George? Any comments on what you're anticipating use of, how you'll use these new techniques?
Yeah, Ryan, I think Dr. Fajadeh explained it. He's had clinical experience with this, and as you know, I haven't had my hands on this in a clinical setting. But knowing the characteristics of these movements, I think it's important to realize that it's not necessarily utilizing one technique for every single lesion, and having these options with different wire movements really allows you to navigate a breadth of anatomies. And there are even times, as you know, in those, as like one of those cases that Dr. Fajadeh demonstrated, where it's almost a subtotal occlusion or a really tight string lesion, you may not even want a lot of wire movement. You may just want to advance it after you rotate on retract and engage the lesion to just advance it. And so there's a variety of different situations that will dictate what wire movement you use. But I think a combination of spin and wiggle would cover the breadth of lesions.
Yeah, Bill, how about any comments from you?
Yeah, I find it interesting that both John and John said, I can't wait to get my hands on it, which is sort of funny when we're talking about robotics and the whole point is to not have our hands on it. I think, the thing that this comes with is these automated features is next comes the ability to use artificial intelligence, deep learning, and machine learning to actually have it identify where different techniques are actually going to be more effective, both in efficiency in crossing and safety in crossing. So as we gather more data and we are able to get more data, both from the fluoroscopic events and from the technical events with the wire, I think we'll have the ability to make these become better and better and let the machines almost self-select the proper technique. I think the next big evolution is actually going to be able to build some sensory information into the wire tip so that it can look at either forces or angle deflection of wire tips or something that starts to inform the wire and inform the robot of what's going on with the wire to allow us to actually further enhance the abilities of the robot to self-cross the lesions rather than us having to self-select.
Yeah, interesting point, Bill. And I think I hear this all the time from people who, are not yet robotics users. They frequently will ask, how do you do, with the loss of the sensation of tactile feel? And my response to that has really become, I think I agree with you completely. Future generations of robotics are going to allow us to do things that are well beyond the perception of our, human fingertips. And so I think stay tuned, for where the future of this is going. So,
and Ryan, I'll just add on a single comment there. Like Bill mentioned, I didn't even realize that I was saying get my hands on it, but we've almost started to react to what we see visually on the screen right in front of us by moving the joystick and really having it react to what we're seeing. And so what used to be a tactile sensation is now an oculo joystick movement response. And so I think it just changes the way you respond to these lesions with robotics.
I agree with that. I think excellent comment. And I will say that, in my clinical use of robotics, I have gotten to the point where I now start every case with the ROR feature on, just because I find it so incredibly user-friendly and easy to use. So I'm curious how my practice will change once I have the full technique series available. So next question for John George. Bill had mentioned in his presentation about the possibility of automation in robotics giving operators a skill set that maybe they currently don't have. And he had a very nice analogy for in golf that you could give non-expert players expert skills. Do you think that robotics, John, is it going to be a one-size-fits-all strategy, or do you think that these automated maneuvers may offer early career interventionalists something different than later career interventionalists? Do you think the same might be true for low-volume operators compared to high-volume operators, per se?
Yeah, I mean, I think that's a great point. I wouldn't quite say that it's a one-size-fits-all, but I do believe that it bridges the gap between high-volume and low-volume operators and a variety of skill levels. Even as technology is advanced with, a wide array of even wires that we use, and stents and crossing catheters with low profiles, our skill level has improved, or the gap between high volume operators and low volume operators have been narrowed. And I think it's going to be the same effect as you have automation of some of these wire movements. And as you know, even these automated wire movements were developed by studying maneuvers by highly skilled operators in complex settings. And so having that technology brought down to everyday operators, it definitely elevates their ability to deal with complex lesions and be able to do what they couldn't do before, perhaps. So it definitely narrows the gap.
And Bill, since you brought up the point, any comments about how maybe less experienced operators might use these differently than higher experienced operators?
Yeah, I guess I would. I think that also comes back to the ageism comment, which is just because somebody's been doing this a long time doesn't actually mean they're that good, and just because you're brand new doesn't mean you're that bad. Because it really comes fundamentally down to your training and your purposeful practice. I mean, if you go out and hit 1,000 golf balls the wrong way, that doesn't make you a better golfer. And so, to me, this bridges the gap. you're never going to make people who are great better. And matter of fact, if you look, most people who are great don't think they're as good as they really are if you look at psychological profiles. What this really does is make the bottom operators much better because you're giving them access to a technology that will make them better. It's sort of like when people went from, blade irons to cavity backs. We went from persimmon to titanium heads, from steel to graphite shafts. You're using technology to bring up the skill set of the bottom. At the top, probably a little bit more difficult, but in the grand scheme of things, this is going to make the top's life a lot better because it'll be less stressful, it'll be less hard, and I actually fundamentally believe it's going to change how we train because we spend most of our training effort on teaching people how to put a stent in. What we really should be training people is how to manage complications and how do we prepare for the bad things that can happen. And so you could actually, by spending less time on figuring out how to balloon, wire, and stent, we could spend more time in how to manage dissections, perforations, hemodynamic collapse, which are actually the things that allow us to tackle harder and harder lesions and harder anatomic and clinical patients.
Bill, I believe your father was a pilot. I've heard you say that before. I think the airline industry is light years ahead of where interventional cardiology is in using automation to standardize workflows, to improve safety. What do you think the barriers are that we face in interventional cardiology to really leverage the use of automation to the same degree that the airline industry has?
So I have a flippant response to it, so I'll try not to do that. My father was a commercial airline pilot with 34,000 hours of flying. He was a flight instructor both on the 727 and the DC-10. And the challenge for doctors is similar to pilots. Pilots are incredibly arrogant. They're very intelligent. They do a high-stress job with a lot of people's lives at risk. And the reason pilots have a much narrower variability in skill set is basically regulatory, that they are forced to do training every 6 months. They are forced to follow checklists. They have black boxes monitoring everything that they do to ensure that they minimize variability. And they also, when accidents occur, it's used as a means to make everybody better, not as a means of crucifying the people who are flying the plane. I think for physicians to adopt this, we're going to have to get our egos out of the way. We need to stop this being about us and feeling threatened by what's going on, but we really need to be about the patients and purposeful self-improvement. And I think really for this to be truly adopted, we need to see regulatory pathways where we're forced to do some of this stuff. I think if we continue to do it with just self-adoption, it will struggle and be much slower, unfortunately.
Yeah, Dr. George, any comments on what Bill said?
No, I think we're learning a lot in just healthcare, the value of having algorithms and automation, and we're starting to apply this in medicine a lot more than we have in the past, and I think that's what robotics brings to the table. It's the idea of removing your false sense of being able to control the situation to an ultimate degree, and recognizing that if you have algorithms in place, if you have automation that can help avoid a lot of complications. And going back to what Dr. Lombardi said, I think that needs to be the key in how we operate.
Yeah, I think excellent points, and I think about these automated maneuvers as they will soon come to market in the U.S. We don't know yet which of these techniques is going to be best. For instance, accessing a difficult side branch, or an angulated lesion, or crossing a CTO. And I think these are all areas that are ripe for research, so that we can begin to develop those algorithms that when you have a lesion or a vessel or a side branch with very specific anatomic features, that we can then prescribe the right automated robotic maneuver to efficiently and safely get you across that. And so I think it's something that we very much look forward to studying. But again, I think with goals of efficiency and safety in mind. So great. And to Dr. Fajade, can you hear me okay? I think he might maybe having difficulty with his audio. Maybe to the other panelists, any comments on the Navigate trial? Dr. Fajade presented kind of the goals of the Navigate trial, some of the endpoints that are going to be looked at. What do you guys see as maybe?
First of all, I would like to come back to the previous discussion, and I think that it's really, I'm sure that in the really close future, there will be first of all the rising in the level of the standard of the performance on the procedure. In the same time, there will be a sort of harmonization, not equalization, but harmonization, using the robotic of the technique performed by the different operators. And I'm sure that at the end there will be an increase of the efficiency, and this will be really positive for the patient, because we will improve the patient care. It's interesting that when you see the difference of an old operator like me, I'm doing interventional cardiology since more than 35 years, and when I compare my technique manually with my fellows, we see the difference in the way to cross a lesion, advance a wire, etc. And this is my job to, to train them, to explain the manipulation of the wire, how to have to do with the fingers. When we are doing a robotic procedure, it's totally different. In other words, they understand that the tip of the guide wire is there. They understand that they have to follow this vessel, to cross this lesion, and place the wire in the distality of the lesion. And it's really impressive to see that they are doing this exactly with the same speed compared to my way of working. So immediately, this technology gives to the young generation, and in the same time for the low volume operator, they will be really raising that their level at the standard of the high volume operator. And this will be really interesting to see in the future the changes that we will see in the result of the way to conduct the procedure, to perform the procedure, the results. And I think that at the end, this will be really positive for the patient.
Yeah, I agree with that. I think excellent comments. And to go back to the prior question, what do you guys see as the kind of greatest benefit to come out of the Navigate trial once it's all said and done?
That's an important point, and we will see. We have already, and we saw during this symposium and the presentation, the four studies that we report positive points concerning the way and to perform and the simplicity and the reduction of the dose of X-ray. What will be interesting from the Navigate trial, it's certainly we can anticipate high technical, clinical, and angiographic success because of this, rising of the standard level for all the operators. I'm sure that the way to control the wire, particularly with a constant speed, you could certainly reduce the procedural complication rate. And particularly, I will see an advantage on the distal perforation with the wire. because when you have the possibility to park your wire, to fix it, and there will be no impact during the manipulation of the balloon or stent on the distality. And sometimes we are doing the, 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 the distal perforation is coming when we are pushing the wire, particularly hydrophilic wire, to distal. So I think that certainly we will use a lower dose of contrast, which would be also important, particularly for diabetic patient or patient with renal failure. Concerning the fluoroscopy time, I don't know. I'm not. Maybe we will demonstrate that there will be a shorter fluoroscopy time, but again, this we have to demonstrate. The wiring time also, the time to, between the distal tip of the catheter and the distal vessel. Certainly, we could demonstrate, particularly quite complex lesion, that we could shorten globally the wiring time. So I think that's, but again, we have to perform the trial and wait to the result. But we could be optimistic on the result of the trial. Yeah. And it's true that concern the precision of the procedure also. This capability that we have to measure precisely the lesion length and in the same time to select precisely the stent length could be a positive point for the patient. In other words, we could certainly reduce a little bit the stent length. We could reduce the number of stents implanted, and again, this will be positive for the patient.
Yeah, I agree with all of those things. And I was interested in your presentation that you had shown an increase in fluoroscopy time and contrast usage in your learning curve. And wanted to remind the audience, I think in Tejas Patel in his recent publication where he did a propensity match analysis, I think in that analysis, he did not see an increase in fluoroscopy time or contrast usage. And so just in the last few minutes, wanted to just briefly talk about two things. One, radiation safety, and two, remote. It seems like I think all the operators here, maybe with the exception of me, have moved their controls to the control room. Is that accurate?
Yep.
Mine's still in the lab, so I'm still archaic in that as well.
So John and I are behind the times. And Bill, I would think that your radiation exposure in the control room has to be zero.
Yeah, it's actually the best thing about having a control room, honestly, is one, we're actually doing our procedure note in orders while we're doing the case. I tend to get a lot of email done while we're doing exchanges. We're actually doing other work. So it's made our daily workflow much more efficient because we're able to sort of get more things done. And my radiation dose is zero and my caffeine intake is up. So because I can drink coffee. So that's a helpful thing in my world.
Yeah. Great.
No, it's true that I fully agree with you. It's very important. And we talk about, of course, the dramatic reduction of X-ray exposure close to zero for the operator, except when you are placing the guiding catheter, and then it's finished. What will be also interesting for people who have a high volume, it's that I'm sure at the end of the day, when you start at 8 in the morning or 7:30 in the morning, and when you perform a procedure at 5 or 6 p.m., after doing a lot of cases, when you are doing all the cases manually, standing at the table for all one day long, I'm sure that because of the fatigue, and particularly when we are increasing in the age, I can tell you, the risk of complication, it's certainly a little bit higher. And so again, when we come back to the patient safety, I'm sure that if you are, spending all the day sitting on your armchair, in front of your screen, manipulating your joystick, the level of fatigue at the end of the day for the operator will be absolutely different. And for the patient, not for the first patient of the day, but for the last patient of the day, could be really a difference in favor of the robotic procedure.
Yeah, I think very insightful observations. So, just in the interest of time, we will have to conclude. Just wanted to make a few final comments. You know, the focus of this discussion was, of course, on robotics and automation, and I think, you know, we are seeing now, I think, a lot of exciting, future prospects in robotics, not just with the potential for automation, but I think also, you know, in remote procedures, which is something we'll continue to work on going forward. And then I think we're also going to see a lot of expansive robotics into the neurovascular space. And I wish we had time to discuss all of these exciting things today, but we do not. So I wanted to thank our panelists for their presentations and all of the insightful discussion. And I hope everybody enjoyed the session. Thank you. Bye-bye.